Okay, Rebecca's back. Okay, so today, we're going to talk about women's health and reproductive rights. Of course, women's health includes their integrity and their bodily integrity, which has been a big part of, very sadly, it's a very big part of the political debate these days. In many ways unconscionable. But we're going to also talk about reproductive rights and women's health. And we're going to do it both in the national context. We've had, for example, a recent Supreme Court opinion and we'll also do it from the international perspective. Ali just joined the leadership team at OneillH. But I wanted to introduce Rebecca Reingold, who's an associate at the OneillH Institute. She was the lead author of the JAMA article on whole women's health and is just really one of our great leaders on women's health. She's going to be moderating it and introducing it. Thank you, Rebecca.
Thanks, Larry.
And you're first going to say a few remarks.
Just a few remarks from the mic since my voice is a little off today. So I just thought I'd give a little bit of an introduction to what we're going to be talking about today. The importance of access to comprehensive reproductive health services is well recognized, not only to improve women's chances of surviving pregnancy and childbirth, but also to support their decisions about if, when, and how to have children. Maintaining one's reproductive health, moreover, contributes to related issues such as gender equality, greater educational opportunities, poverty reduction, social justice, and the full realization of human rights. Yet for many women around the world, reproductive health outcomes remain extremely troubling. Every day last year, 830 women died due to complications of pregnancy and childbirth. All of these deaths occurred in low-resource settings, and most could have been prevented. In developing regions where abortion is often highly restricted, it's estimated that 6.9 women are treated for complications from unsafe abortions, and yet only 40% of women are even treated for those unsafe abortions. And it's estimated that 225 million women still have an unmet need for modern contraceptives. In addition to lacking access to essential services such as antenatal, perinatal, postpartum care, essential obstetric care, contraception, and safe and legal abortion, women can experience violence when attempting to seek such services or be subjected to non-consensual health interventions such as forced sterilization. Moreover, health indicators related to reproductive health tend to show very wide gaps between the rich and the poor, between folks living in urban and rural areas, between countries, and also within them. In addition to women who are poor and those who live in rural areas, other groups of women are more likely to face substantial barriers when trying to obtain information about or seek reproductive health services, such as those who are racial or ethnic minorities, young, HIV positive, sex workers, the list goes on. So whether a woman has access to appropriate and effective reproductive health services and whether she is subjected to unnecessary reproductive health interventions is therefore often determined by numerous and intersecting economic, political, legal, social, and cultural factors. Today, our distinguished speakers will discuss these factors and also provide some examples of the legal and policy solutions that have been employed to ensure that women, both here in the US and also around the world, are able to achieve and maintain their reproductive health. So I'm just going to quickly introduce our speakers, and then each one will come up and share their remarks. First, we will hear from Dr. Victoria Jennings, who will discuss a human rights-based approach to family planning policy development and implementation. Professor Jennings is director and principal investigator of the Institute for Reproductive Health at Georgetown University. She has more than 30 years of experience in developing, managing, implementing, and advising family planning/reproductive health programs in capacity building, evaluation, and advocacy. As director of the Institute for Reproductive Health, she leads USAID-funded Fertility Awareness for Community Transformation Project, which is testing innovative strategies to increase fertility awareness and expand access to fertility awareness-based methods at the community level. She's also professor at the Department of Obstetrics and Gynecology at Georgetown University Medical Center. Then we will hear from Erin Chevet, who will talk about the challenges related to accessing reproductive health services in the U.S. and the exportation of harmful reproductive health restrictions in U.S. foreign policy. Mr. Chevet serves as Senior Policy Counsel and Manager of Special Projects at the Center for Reproductive Rights, a global human rights advocacy organization that's dedicated to using litigation and advocacy to advance reproductive freedom in the U.S. and around the world. And in that capacity, he's responsible for advancing the center's priorities at Capitol Hill, at the White House, and with executive branch agencies. Finally, we will hear from Alicia Yamin, who will discuss a landmark case relating to maternal mortality that was brought before CEDAW, an international human rights treaty monitoring body. Professor Yamin is our new director of the Health and Human Rights Initiative at the O'Neill Institute. Prior to joining O'Neill, she was a lecturer on law and global health at Harvard School of Public Health, director of the JD-MPH program there, as well as policy director of the FXB Center for Health and Human Rights. Professor Yamin currently serves as a panelist on the Secretary General's Independent Accountability Panel for the Global Strategy for Women's, Children's, and Adolescents' Health, and a commissioner on the Lancet O'Neill Institute Commission on Global Health and the Law. And with that, I will hand things over to Victoria.
Thank you so much, Rebecca, and thanks to everyone for inviting me and for coming today. This one right here. Okay, great. Thank you. As Rebecca has said, I would like to talk with you today to open up some ideas and some issues around human rights and family planning, from policy to implementation. And the narrative that I think of when I think of this topic is what policies are and then what happens when implementation occurs. And it's not always what you might think. There would be some unintended consequences, some good, some not so good. So let's think about these in this context. Just to say for one moment that the Institute for Reproductive Health is supported primarily by the U.S. Agency for International Development, also by the Bill and Melinda Gates Foundation and a number of other foundations. We've been at Georgetown for about 30 years, and we're based in Georgetown University Medical Center, where I and the other faculty members there have our faculty appointments, although 0 of us are obstetricians, gynecologists. I guess it's sort of a Georgetown thing, I'm not sure. Anyway, okay, so the history of family planning as a human right is something I'd like to discuss first. And it's actually going to be a history that doesn't go back very far in time, because you could go back quite far indeed, particularly if you're looking at it from the U.S. perspective. But thinking about it on the global stage, family planning really became, or population programs, really became a thing in the 1960s and 70s. Not really very much going on before that. But just to look at some of the consensus statements that have come after laborious discussion from a number of conferences around the world that have been held on this topic over time. In 1968, the Tehran International Conference on Human Rights stated that couples have a basic human right to decide freely and responsibly on the number and spacing of their children, the right to adequate education and information in this respect. But what is missing from that statement? Where does they have the right to the means to achieve that? They have the right to the information, the education, they have the right to do it, but how? How does implementation occur? But that's okay. It was 1968. It was just then on the global stage. People were beginning to think about it, but it took a while for the thinking to really begin to evolve. In 1974, the World Population Conference in Bucharest. Now, one thing you might notice is that both of these conferences have occurred in capital cities that are not exactly known for human rights. but who's counting, right? Reproduction, family formation, and the status of women. So the issue of the status of women began to come in to the rhetoric. It is recommended, certainly not required, recommended that all countries respect the right of persons to determine free, informed, and again, that comment, responsible manner. Responsible is kind of a loaded word. Often it meant you really shouldn't have too many children, all you people over there in Africa. You're being irresponsible. So it's important to think about that concept. Encourage appropriate education concerning responsible parenthood. And here, for the first time, we're making available to people who want this advice, who want to, let's say, avoid a pregnancy, the means of achieving it. That's really the first time this has come up in one of these global statements. Jumping ahead, in 1994, the International Conference on Population and Development in Cairo, again, a bastion of human rights, the aim of family planning programs. Now we get to the idea that there's actually some kind of a programmatic approach to family planning, must enable couples and individuals. This is one of the few times that the idea of couples, that men have anything to do with this at all, that men have any rights around this issue either. This is really the first time that that has come up. And individuals to decide freely and again responsibly the number and spacing of their children, and having the information and the means to do so. And here we begin to see another issue that is really near and dear to my heart, the issue of informed choice, making available a wide range of safe and effective methods through these family planning programs. So you can see how the thinking is beginning to evolve. But it's been around rights-based issues all along. It's just a question of how one interprets that and what you emphasize. By 1994, there was significant planning, significant funding, and significant programming in virtually every continent around family planning. There were services available through ministries of health, through family planning associations, not available to everybody, certainly not available everywhere, but they existed. So the concept was beginning to really take off. By 2014, the World Health Organization talks about ensuring human rights in the provision of contraceptive information and services, and again, talk about including a range of family planning methods in the service delivery context. And here, for the first time, without discrimination. Now, who might be discriminated against? How about programs that say, we don't serve young unmarried women? Or programs that charge for services beyond the capacity of many women to pay? Or programs that offer certain methods to some women and other methods to other women? These are things that are beginning to be a concern. Now, there is an initiative going on at this point that you may or may not have heard of. Certainly everybody in my field knows about it, but I'm betting that you're not all reproductive health people, so maybe you haven't. Family Planning 2020. It is an initiative that was really sparked by the Bill and Melinda Gates Foundation, and every single funder has jumped on the train, and lots of the organizations around the world that are involved in service delivery, research, advocacy, et cetera, have gotten behind this initiative, and people are working towards the goals of FP 2020, which we'll get to in a moment. But here I want to stress again that it has rights and empowerment as the underlying the principles of this initiative, a full range of safe, effective, and available contraceptive methods. Barrier methods, short-acting methods, long-acting reversible methods, permanent and emergency contraception, et cetera. Pardon me. So the focus of FP 2020 is on the fact that was suddenly realized about 2012 that there were about 220 million women around the world who have an unmet need for family planning. Does anyone know what an unmet need might be? Well, we'll get there in a minute. I'll define it in a minute. But the goal is, look at it, it's very numeric. It's very targeted on a number. 120 million more women using family planning by 2020. There's nothing there in that goal about human rights. There's nothing in that goal about choice, but rather 120 million more women using family planning by 2020. So the initiative has been applauded for its focus on really getting services out there, because that's obviously clearly important, but it has been criticized for its numeric targets. Rather than saying, provide family planning services to women worldwide, we want women using family planning. So it may be a question of wording, it may be nuance, and it may not be. Now, in general, I think we all can recognize very easily the global benefits of family planning use, and indeed, there have been some really important gains for global development and women and children's health around the world, even if you just compare the 2012 and the 2015 statistics. 2012, when Family Planning 2020 started, and 2015, when these were collected, you can see that there are lots more, there are 24 million additional users of modern family planning methods. Believe me, we're not going to get to 120 million. That has been well recognized. We will not achieve that goal. 2.1 million unsafe abortions averted, 13,000 more averted maternal deaths, and one number that I would like to focus on, the 6.6 million more unintended pregnancies averted. Pregnancies averted. But look at the word unintended. We're going to come back to that. So an unintended pregnancy is women who say that their current or last pregnancy was unplanned or unwanted. There's a big difference between unplanned and unwanted. And there's a big difference between saying, wow, I really didn't plan to get pregnant right now. And another one's that, and saying, well, you know, I didn't plan it, but it's not such a bad thing. So there's a lot of nuance around all of this terminology. So the statement is that at least one half or more than half of pregnancies in the US are unintended. But on what point in the scale unintended? How unintended? As many as 80% in some low-resource settings. But again, what's unintended? Sometimes it just happens, you know. So it's kind of it's a bit of a murky figure. Well, why aren't women using family planning if they say they don't want to get pregnant, if they don't intend to get pregnant? Why aren't they using family planning? About a quarter of them say it's because they're concerned about the side effects of family planning methods. Have you ever heard of that? Have you ever known anybody who didn't want to take a hormonal contraception, for example, because of concerns about side effects? It's extremely common. And the same concerns exist all around the world. It's not like just women in New Jersey and women in Kenya. It's literally women everywhere. This is a pretty consistent statistic. A lot of women saying, well, you know, I don't have sex all that often, so I think I can get by without it. That's not at all uncommon. Not at all uncommon. In fact, again, about a quarter of women who are not using family planning say this. A lot of women say, well, I'm breastfeeding or my baby's just 3 months old, so I can't get pregnant, without really understanding what the physiology is of the return to fertility postpartum. This is a very common misunderstanding, and it often does result in a too soon pregnancy postpartum. And then there's a lot of opposition to family planning, not just in this country, believe me. It is far more significant in a number of countries around the world than it is here. Opposition, official opposition, opposition by the husband, opposition by the mother-in-law, opposition by the woman herself, for a wide variety of reasons that may be related to religious issues, that are probably much more related to gender and family planning, gender and equality and lack of opportunities for women in the first place, and a whole bunch of other things that form that constellation that disempowers women generally. Okay, so let's talk for just a second about the range of family planning methods, because that issue certainly did come up. Sterilization, a medical intervention, it requires a highly skilled medical intervention, extremely effective and permanent. The long-acting reversible contraceptives like IUDs and implants, again, a reasonably high level of medical intervention, extremely efficacious, reversible with medical intervention like taking them out, which doesn't always happen, and there are some side effects. And then there's a range of user-controlled methods such as oral contraceptives, injections, condoms, diaphragms, fertility awareness methods, various variable effectiveness, but highly effective if used correctly. All of these methods are. If used well, they're very effective, and also quite variable in terms of side effects. So this is what we mean by a range of methods, but not all methods are always available. And in most countries, over half of all family planning use is by one or two methods, such as in India, with a very high level of sterilization, mostly female sterilization. Bangladesh, injectables primarily. Indonesia, injectables primarily. Egypt, IUDs primarily. Benin, there's not very much going on in Benin in family planning. People are using a lot of traditional methods. Ethiopia, 73% injectables. In Ethiopia, the government is really pressing on injectables. That is the method of choice for the government. For reasons that we can only imagine, these long-acting reversible contraceptives like IUDs and implants, there is an extremely high level of enthusiasm among donors for these methods, an extremely high level. As a result, there is a lot of policy that is in place, a lot of policy and norms and training and so forth of providers that are basically LARCs first, offer long-acting reversible contraceptives first, and if they won't use that, okay, then you can move on to something else. But it's very, very focused on LARCs first. For example, performance-based financing in a lot of countries in Africa, where the facility or even the provider receives a financial benefit for providing certain services, tends to favor long-acting reversible contraception. Voucher programs that give vouchers to women that say go to the facility and get a method of family planning tend to favor long-acting and reversible contraception. I was on a panel at the International Family Planning Conference in Indonesia earlier this year about human rights and family planning. There were people in the audience, and I just wrote down some of their comments. All they want us to report on is LARCs. They don't care about other methods. The government wants us to promote LARCs, especially in rural areas. The choice approach, which is the way the LARC program has been developed in the U.S., pushes LARCs, especially in low-income communities and for adolescents. So maybe everybody doesn't get quite the same services. So as we think, as the other speakers talk with you today, or talk with us today, I'd like to think about how this implementation of policy may inadvertently relate to eugenics approaches from early 20th century United States, or sterilization laws that affect the disabled and poor women of color. Welfare benefits in the U.S. that have been contingent on LARC use or sterilization, and mass sterilization programs in some countries such as India. Just thinking about what is informed choice, and how do women's desires fit into this? reflect on individual circumstances, the relationship context, pregnancy ambivalence and future plans, the experiences of family and friends, and the ease of discontinuation. If you have an implant, you want it removed, but the provider either isn't trained, isn't there, or doesn't want to do it, or will charge you money for it. How does that affect choice and human rights? So focusing on the woman instead of the method is what I would like to think that we're doing, and it's what those policies all say. But when when it comes down to implementation, it doesn't always happen quite that way. So, thank you.
Let's see if this is going to work if I put this here. All right. Well, thank you very much. It's really wonderful to be here. I'd like to start with a quotation that you probably will recognize. The ability of women to participate equally in the economic and social life of the nation has been facilitated by their ability to control their reproductive lives. It's a line, of course, from Justice Sandra Day O'Connor, the first and at the time only female Supreme Court justice in the Planned Parenthood versus Casey case, which I'll talk about in just a few minutes. But I think it's important for us to keep that in mind the whole time, that while we are talking about reproductive health, health is not the only thing that's at stake here, and that this really is fundamentally much bigger than health, and it fundamentally is about women's equality, something that Justice O'Connor recognized. And while I don't want to talk about it at great length right now, I do want to also mention that it's about equality in a broader sense, in that in the United States and also around the world, broadly speaking, it's something that you'll hear about in the OneillH case as well, that reproductive health outcomes are very, very much a function of economic class and of race. The United States ranks 47th in the world. We have a 50% higher maternal mortality rate than Libya. We are far behind Kazakhstan. And that's the United States as a whole. The worst jurisdiction in the United States for maternal health outcomes, you're living in it, Washington, D.C. Beyond that, we know that women of color and poor women have much worse maternal health outcomes. We also know that they have much greater needs for unmet need for contraception in the United States, have much greater rates of unintended pregnancy. So all that just to keep in mind in the back of your head. So I'll be speaking, of course, with the Center for Reproductive Rights, although my remarks themselves will be in my own individual capacity. And I want to thank Rebecca Reingold, Professor Larry Gostin, Professor Jeffrey Crowley, and the OneillH Center as a whole, and including its executive director, Oscar Cabrera, who's both a colleague and friend. The Center for Reproductive Rights has been around for about 25 years, and I should note, given the presentations today, that we're the organization that litigated the Whole Woman's Health versus Hellerstedt case that I'll be talking about. We also are the organization that litigated the OneillH case that you'll hear about in the following presentation. So I want to give you a quick roadmap of what I'd like to talk about, and it's a lot of ground to cover, so hopefully you won't mind me speaking a little bit on the quicker side. Hopefully that works for people, although if I speak too quickly or not clearly enough, please do raise your hand. First, I want to talk a little bit about the issues around access to clinics. Second, around affordable reproductive health care. Third, about religious entitlements. And fourth, about exporting harmful policies overseas. So let's begin at the beginning with Roe versus Wade, 1973. The right to abortion stems from a privacy right under the Due Process Clause of the 14th Amendment. It's a trimester approach. We then, 20 years later, have Planned Parenthood versus Casey in 1992, the quotation I just read you from Justice O'Connor's concurrence, where the trimester approach is sort of morphed into an undue burden standard. There's a right to abortion until viability. After that, it can be restricted or even prohibited, as long as there are some exceptions. That abortions before viability are protected by the Constitution, and that the states may not implement or put in an undue burden. An undue burden meaning, according to the court, something that has the purpose or effect of placing, and that's important, purpose or effect, either, of placing a substantial obstacle in the path of a woman seeking an abortion of a non-viable fetus. The problem, of course, to some extent, is what is an undue burden? It's a burden that's undue. Even Justice Scalia at the time in his dissent in the case, said that he thought it was a term of phrase that was inherently manipulable and somewhat unworkable. And there's some validity to that. As states moved to fill in the vacuum after Planned Parenthood versus Casey, enacting around 1,000 different abortion restrictions, including 334 restrictions that have been enacted by the states just since 2010. There's a broad range of restrictions that are out there, from unconstitutional pre-viability bans on abortion to restrictions that interfere with the practice of medicine by mandating unnecessary procedures. Of these, Texas HB 2, House Bill 2, included 2 provisions. First, admitting privileges, saying that in order to provide abortion services, the doctor had to be have admitting privileges at a local hospital. At first blush, that sounds fairly reasonable. Why wouldn't you want to have admitting privileges? Until you realize that admitting privileges are not something you earn, essentially, by having a certain level of medical expertise. It's something that's completely discretionary based on the hospital, oftentimes based on, do they like this doctor? And is the doctor bringing in a lot of patients into the hospital? And in the case of abortion providers, there was not a lot of love, largely because it would attract protesters and hospitals felt like it would be bad for business. And because abortion is so safe, they were in the enviable position of not bringing much business at all to hospitals. The second requirement in HB 2 is an ambulatory surgical center requirement, requiring abortion clinics to essentially be mini hospitals, a vast array of regulations, including the width of hallways and doorways, how many water fountains, and so on. Again, not based on any sort of rational medical justification and not imposed on other outpatient medical providers providing procedures of similar risk and complexity like plastic surgery or colonoscopies. The law threatened to shutter about 3/4 of the abortion clinics in Texas, of course, one of the largest states. Before HB 2, there were 40 different facilities, but once HB 2 went into effect, that number was cut in half. Huge swaths of the state without abortion access for hundreds of miles, and 11 of 13 clinics outside of major cities would have closed, causing people to literally have to drive hundreds and hundreds of miles. On the flip side of the bill, there really was no medical benefit. Again, abortion is an extremely safe procedure, something like 14 times safer than childbirth. And there was no evidence that these laws made the abortions any safer. There was some evidence of anti-abortion animus. So, for example, Governor Rick Perry stated that, quote, "The ideal world is one without abortion. Until then, we will continue to pass laws and ensure that they are as rare as possible." Or alternatively, Texas State Representative Jody Laubenberg, the author of the bill, "I am so proud that Texas always takes the lead in trying to turn back what started with Roe versus Wade." The decision in the case, again brought by the Center for Reproductive Rights representing whole women's health, was a major victory. And the question before the court was, did the court have to take the claims that were made with the bill that this legislation, the HB 2, was motivated by women's health, or could the court scratch the surface and acknowledge the sham that was going on, that these laws were essentially designed to regulate abortions out of existence? And Justice Breyer, who wrote the court's opinion, stated that these restrictions provide, quote, "few, if any, health benefits to women," as, again, abortion is an extremely safe procedure already. The claimed health benefits were, quote, "not sufficient to justify the burdens upon access that each imposes, such as clinic closures, increased travel distances, fewer doctors, overcrowded clinics, longer waiting periods, and so on." Each provision posed a substantial obstacle to women seeking abortions, thereby violating the U.S. Constitution. Despite the victory, of course, there is an ongoing impact for the women in Texas. The clinics that were forced to close as a result of HB 2 will take time to come back online, and so abortion access and reproductive health access more broadly in Texas will be diminished for months, if not years. Now, other similar laws are presumably unconstitutional. The court declined to review challenges in Mississippi and Wisconsin, allowing lower court decisions to stand. A Louisiana law was blocked, and so on. But these bad laws, and this is important, these bad laws don't go away on their own. It's not as though the Supreme Court makes a decision in one case, and all of a sudden all similar laws in all states simply evaporate. That's not what happens. They only go away when they are challenged, which means that you have to litigate and litigate and litigate, even if you win. Obviously, it's easier to win once the Supreme Court has said a certain kind of restriction is invalid. But there's more and more restrictions that keep on coming. In fact, this I found quite shocking myself, and I do this for a living. Between January and July of this year, state legislators introduced 445 anti-abortion provisions. That's just in 6 months of this year, nearly 500. The fact that these have to then be attacked one by one with litigation points to the need, from our perspective, for congressional action. And there's a bill, the Women's Health Protection Act, H.R. 448 or S-217, that would do that. It would preclude similar laws from being enacted in the states. It would cover the laws in question in the Texas case, but also go beyond them, precluding states from having laws that impose unnecessary medical procedures, medically unnecessary trips or tests, pre-viability bans, or laws that restrict access to medication abortion. There's also a catch-all provision that looks to the impact on women and providers of a given bill, and then also looks at the medical benefit, of course, exactly what the court ended up doing in the Whole Woman's Health case. So turning from legality of abortion and keeping the clinics open, I want to talk for a few minutes now about affordable reproductive health care. And of course, everyone knows Roe versus Wade, Planned Parenthood versus Casey, and now folks know Whole Woman's Health versus Hellerstedt. But a lesser-known case that you might not know is Harris versus McRae from 1980. The case involved a challenge to the Hyde Amendment that almost completely banned the use of Medicaid funds for medically necessary abortions. During oral argument, in fact, the Solicitor General, in a very telling exchange, said that the case would be no different if it required a life-saving abortion. In other words, the government said, we have literally no obligation to allow you to use the Medicaid system to have any abortion, including a life-saving abortion. If you need a life-saving abortion, you don't have a right to one under Medicaid. The court ruled that freedom of choice does not imply a constitutional entitlement to the financial resources to avail herself, the woman, of the full range of protected choices, and it rejected an equal protection claim. But Justice Brennan wisely recognized this as essentially an end run around Roe, an attempt by Congress, in his words, to circumvent the dictates of the Constitution and achieve indirectly what Roe versus Wade said it could not do directly. And Henry Hyde, the author of the Hyde Amendment, himself said this. He said, quote, "I certainly would like to prevent, if I could legally, anybody from having an abortion, a rich woman, a middle-class woman, a poor woman. Unfortunately, the only vehicle available is the Medicaid bill," again, going after poor women and going back to my comments that I started off my remarks with. Justice Brennan also recognized the coercive nature of the Hyde Amendment, with the government paying for expenses associated with child care and birth, but not any of the expenses of an abortion. And of course, again, an impact on poor and racial minorities, and in particular, black women. Worse yet, even those very limited exceptions in the Hyde Amendment, which currently has a life, rape, and incest exception, are not being implemented. In fact, a 5-year study by IBIS Reproductive Health found that most women who should qualify for one of these very, very limited Medicaid coverage of abortions are still unable to get that coverage. And that these coverage bans exist broadly still today, not just for people on Medicaid, but also for federal employees and their dependents, women in the military, Peace Corps volunteers, and women who get their medical care through the Indian Health Service. It also prohibits the District of Columbia's local government from using locally raised funds to pay for abortion. Thanks, Congress. And I'll tell you that this sounds already draconian enough. I had the opportunity to work on some of the advocacy. Up until about 2 or 3 years ago in the military, there was only a life exception. There was literally no military coverage even for rape in women in the military. The Peace Corps was even worse, and that's something that I spearheaded a lot of the work on, had literally a total abortion ban. Even life-saving abortions would not be covered under the law, and we were able to get that changed, but it took 30 plus years to do. So, there hasn't been a real challenge to Harris versus McRae, and so legislative response, again, is what's required. In this case, another bill called the Equal Access to Abortion Coverage and Health Insurance Act, or the Each Woman Act, which would require full abortion coverage whenever the government acts as an insurer, as it does for federal employees or for the Medicaid program. So from there, I want to talk now a little bit about what I'd like to refer to as religious entitlements. And these are the use of claims of religious liberty to undermine reproductive rights and health of others. Now, of course, we all love and respect religious liberty, the freedom to believe and exercise one's religion. But it ultimately is a shield to protect religious exercise and not a sword to undermine the activities and health and well-being of others. Unfortunately, there are numerous ways that religion is being used and claimed to harm others. And the most prominent example going on is, of course, around contraceptive coverage under the Affordable Care Act and its intersection with the Religious Freedom Restoration Act, or RFRA. There's strong evidence that we know that cost is a barrier to contraceptive access for a sizable number of women, and that broader contraceptive choice leads people to use better, more effective, but more expensive contraceptives. the contraceptive coverage benefit, which was opposed as sort of an adjunct to the ACA, would have no copay for all FDA-approved contraceptive and counseling. And the background to this, of course, is that 99% of all women who are sexually active in the United States, including 98% of Catholic women, have used contraception during their lives. This ought not be controversial, but it is, at least to some. For example, you can think of the times America was attacked. One is December 7th, that's Pearl Harbor Day. The other is September 11th, that's the day the terrorists attacked. But I want you to remember August 1st, 2012, the attack on our religious freedom. That is the day that will live in infamy, along with those other dates. Representative Mike Kelly in the US Congress. So there's definitely a lot of fervor around this. And of course, folks are familiar with the Hobby Lobby case that extended the accommodation that was given to nonprofit employers to closely held for-profit corporations under RFRA. But Zubik, the case that the Supreme Court decided earlier this year, raises a whole new issue. The Hobby Lobby was where a private corporation sought to take advantage of an existing accommodation extended to nonprofit employers for which it was previously ineligible. But under Hobby Lobby, at least according to the court, the women ought to or should, or in the words of Alito, ought to, the impact on women, according to Justice Alito, would be zero, that women would still be able to get seamlessly the contraception to which they would otherwise be entitled. Now, we question that, and we think that that's actually not accurate in terms of its depiction of facts, but the sentiment is right. It ought to be like that. The challenge with Zubik, where there was an objection made to filling out literally a one-page form, that it's too great a burden on religious beliefs, is much more dangerous than Hobby Lobby and sets a very alarming precedent. Sadly, the Supreme Court punted on this issue, didn't issue a decision, and now it's sort of in the regulatory world, and we'll see what happens from there. I'll move forward a little bit. The other issue I think that's highly relevant here, especially at a Jesuit institution, is what happens at religious and generally speaking Catholic hospitals, where there are a set of ethical and religious directives, ERDs, that under the hospital's rules allow people, doctors, or actually require doctors, to not give the full standard of care in the guise of not permitting abortion. So for example, sterilizations, or including postpartum sterilizations, which are medically recommended directly after birth, because sort of for the reasons that you can imagine, are not permitted at Catholic hospitals. You also have other issues where people, for example, having an ectopic pregnancy are literally forced to bleed until the fetal heart tone stops, because they won't allow the doctors to actually tend to them. I mean, that's in a peer-reviewed journal. You can take a look by Lori Friedman did some fantastic research on that. And in some cases, the hospital, the doctors literally had to disobey and risk being fired or terminated. There was a case out of Phoenix where the hospital manager who permitted a life-saving abortion was then excommunicated by the Catholic Church. So it's a lot of problems with that. And then finally, I'm going to just talk very briefly about how these and sometimes harmful policies in the United States are being exported overseas. So a longstanding provision of both funding rider and law is the Helms Amendment, which prohibits foreign assistance from supporting abortions, quote, as a method of family planning. And it's a bad policy in the context of tens of thousands of deaths each year due to unsafe abortion and millions of instances of morbidity associated therewith. And we know that nearly half of all abortions worldwide are unsafe. Almost all of those are in the developing world. The problem gets even worse, though. That's sort of Congress's problem to fix the Helms Amendment. The problem is the current implementation of the Helms Amendment. This might surprise folks who would assume that that's not an issue today. The Obama administration's position, this president's position, is that the Helms Amendment does not permit any abortions whatsoever. And so President Obama has prohibited foreign assistance from providing abortions, including in the cases of incest, including in the cases of rape, and including in the cases of life endangerment. That is something that we've been trying to get President Obama to change his mind on for 5 years. It has not yet happened. But the United States categorically will not allow even life-saving abortions for women overseas. In fact, USAID's internal regulations treats abortion commodities the same way it does luxury goods and gambling devices, things that are categorically, USAID should never be buying gambling equipment. I think we can all probably agree that that's the right way to do it. But abortion is literally in the same list of things that cannot be ever purchased. One mission said, quote, I think concerning rape and gender-based violence in countries that allow for abortion in cases of rape, we are resigned not to do it if we get U.S. funding. We work with U.S. missions in the country, and they don't want us to touch it. This is not under previous president. This is under the current president. I will also add, even President George W. Bush, certainly not someone who's necessarily favorably disposed towards abortion access, issued a presidential memorandum explaining that as a method of family planning does not cover life-saving abortions or abortions in the case of rape or incest. But the current administration's perspective is more conservative on that issue. And there's also evidence that the U.S. has then directly influenced a number of other countries. There's an example of Kenya, which has a very high maternal mortality rate, largely due to unsafe abortion. USAID, a couple of years ago, told its grantees in Kenya not to attend a meeting to discuss ways to reduce maternal mortality because a reproductive health and rights approach might be used, and that would be prohibited. And the very next day after sending out this email, the Kenyan Ministry of Health, under pressure, withdrew the abortion guidelines, and we, the Center for Reproductive Rights, is currently litigating that today. That's a lot of issues, I know. I tried to give kind of a very broad overview, and I look forward to the discussion afterwards. Thank you very much.
Okay, great. Okay, thank you very much. And it's really a delight to be able to come after these two excellent presentations, which set out some of the things that I wanted to talk about. In discussing what to do today, I thought I'd focus in on one case, but try to illustrate some broader issues in the field with that one case. Maybe I'll, the first thing I guess that might, for those of you who haven't taken reproductive health or rights previously, it may be apparent already from the two previous presentations, but it's useful to understand, I think, that reproductive rights include issues around autonomy and control of bodily integrity and choice. And they also include access to endowments and entitlements. And those kinds of rights have been recognized in domestic as well as international law in many settings, but have not always been applied with a gender perspective to realize what they mean for women and in women's lives. So the first thing I want to do is talk a little bit about the context in which Oline de Silva came up. And it's very nice to have Aram here who can add in anything he wants on the case. And then talk about its normative importance. I hope you all were able to read the CEDAW concluding recommendations. And then go beyond the normative recommendations. I was very glad that Victoria spoke about implementation of policies and laws, because I certainly come from a socio-legal perspective, and in health, I think we all need to go beyond the symbolism of good judgments and good laws to how they actually get implemented in health systems and change people's lives. And then I want to go back to context and talk about the case a little in light of what is going on now and the Sustainable Development Goals. I'm going to start not quite as early as Victoria did, but in the 1990s with UN conferences, and in particular with the one that Victoria mentioned, the International Conference on Population and Development that was held in Cairo in 1994, which addressed family planning in the ways that she said, but also was, I think, a significant paradigm shift, which, at least at the rhetorical and discursive level, shifted population policies from being driven by demographic imperatives to having them really put women, human beings, women, and their choices over their lives at the center of those policies. It also brought together a lot of disparate aspects of what is reproductive health that we now consider reproductive health, but had previously been treated in isolation largely. So family planning, sexually transmitted infections, maternal health, and brought these disparate elements together under an umbrella concept of reproductive health, which also changed paradigms in global health. That discursive paradigm change obviously was very politically contested and controversial, and was added to a year later by the Beijing Declaration and Platform for Action. And both of them essentially said, well, if you put women at the center and women's choices, that really requires kind of radical power shifts in personal relationships, in institutional structures, in political arrangements, and requires political and social change and economic change. And there was a big backlash. So one of the things to take away from this field in general as an issue in global health and global health law is, and I think this came through very well in Aram's presentation, there is a lot of legal mobilization, probably more intensively than in any other area of global health, and there is a lot of counter-mobilization. It is not a linear process, and there are lots of double backing and interesting digressions along the way. So there was an enormous backlash against the reproductive rights and the ICPD vision by the Vatican, by evangelicals in the United States, by conservative Islamic states, and there was also, I have to say, self-critically, in our side, there was still in the mid-1990s a lack of understanding of how to operationalize or implement these very broad goals in real programs on the ground and what that would mean. So there was a lot of rhetorical pasting of Cairo language onto existing kinds of programs. So then we get to the year 2000, the Millennium Declaration, and 2001, where that quite broad, people-centered declaration for development was boiled down into 8 development goals, one of which related to maternal health. So it was not sexual and reproductive health and rights anymore. It was MDG 5, which was reducing the maternal mortality ratio. And that was a very, very deliberate and every word of the Millennium Development Goals and the way the targets are phrased under Goal 5, there were targets about MMRs, maternal mortality ratios, and about skilled birth attendants initially. And it was not until much later, halfway through the Millennium Development Goals, that other targets and indicators on access to contraception and sexual and reproductive health were added. So that's what was going on at the beginning of the 2000s. At the same time, some very important developments had happened in international human rights law. During the 1990s, the 1980s and 1990s, economic and social rights had begun to come of age. The soft law norms that were announced in Cairo and Beijing were very slowly seeded, S-E-E-D-E-D, into progressively more binding instruments, general comments and general recommendations, which then became part of concluding observations by different treaty monitoring bodies. There was and a lot of this, I have to say, was done by the Center for Reproductive Rights, which I've been working with since the beginning. So there was a good amount of work happening in the human rights field that enabled the idea of a right to health entitlements to be formulated. At the same time, in constitutions around the world, economic and social rights were incorporated, and in Latin America in particular, constitutional blocks were incorporated in new post-dictatorship constitutions that allowed for the use of international human rights at national level. And at the same time, the HIV/AIDS pandemic was happening. And in 1996, there was the promise of effective antiretroviral therapy that would turn a death sentence into something that was manageable. And similarly, in maternal health, during the mid-1990s, a shift was occurring from the idea that women needed to be ranked according to risk, and obstetric complications needed to be predicted and prevented, to the realization that the overwhelming majority of obstetric complications are neither predictable nor preventable, but are treatable with emergency obstetric care. I happen to be working at Columbia with the people who were developing this change in paradigm and the UN guidelines that then followed. My own thinking and work on this has been very influenced by that. I published the first article about emergency obstetric care as a right under international law. I, at the very beginning, needed to convince the Center for Reproductive Rights that this actually might fly, but things take time. Anyway, by the early 2000s, when the appetite for other kinds of sexual and reproductive health and rights was very low in international circles, the idea of using maternal health and maternal mortality, which is related to abortion, which is related to access to contraception, obviously, as a kind of Trojan horse, because that's all we had. We had MDG5. We didn't have all of Cairo or Beijing. To get at some of these human rights dimensions back into development was gaining more and more credence. And so a series of things happened. A series of Human Rights Council resolutions were issued leading up to a UN technical guidance on what human rights-based approaches to maternal mortality and morbidity are, which included both abortion and access to contraception, but was very much more directive. And a series of things also happened on the development side in terms of recognizing that very siloed, very technocratic approaches I would say by 2007, 2008, leading up into the Secretary General's first global strategy on women and children's health, there was an idea that these very technocratic approaches actually are missing something. There are enormous inequities and disparities that we're not addressing. There's a lack of accountability. There is inequity in aid eligibility, and a whole series of other things that began to kind of be percolating in the development community as well around 2010. So that was a very good entry for maternal mortality. And it is not a coincidence that it was in the sort of second part of the Millennium Development Goals that the center brought this case in Brazil, the OneillH case. It was in that context where all of a sudden the center that in Latin America had focused almost exclusively on abortion with an important case on sterilization in Peru that I was involved in, and another case of rape by a physician in Peru, and a few other cases had really been hammering on abortion. It is not a coincidence that advocacy, they were really looking for a case on maternal health. So I think it's a small enough group, so I can ask you, I'm hoping that some of you were able to read the CEDAW recommendations. Does anybody recall the basic fact pattern? Yes?
A woman was 6 months pregnant.
Seven,
and-
yeah.
no, 7. And she started feeling
Maybe you
nauseous.
should get up, because if this is gonna be the facts, everyone should hear.
Okay. Well, she started feeling nauseous and disoriented. And she seeked for medical attention. She got to the hospital, and well, the baby they couldn't find a heartbeat, so the baby was dead. So stillbirth. And then she got out of the hospital, and she went back home, and she kept on feeling weak, and so she went back to the hospital, and there she waited until she didn't get any care, well, not adequate care, and well, she died waiting to be.
Those are the general kind outlines of the case. What is important is that she initially, Aline, who was delivering her second child, went to one health center in Belfort Roxo, outside of Rio de Janeiro. And there they really didn't treat her. And she was having all of these problems. And they delayed a very long time before they transferred her to this other hospital in Nova Iguaçu. And so that is important because Belfort Roxo is a private institution. So what did the CEDAW committee find as violations? This is why this case is really taught as a landmark case. By the way, the Aline case, I was consulted from the beginning on the fact pattern. It came about, and the reason it was litigated as opposed to others is an interesting story in and of itself, but it's also not a typical maternal death, because it was not completely clear. There was a claim by the government that it was digestive hemorrhage. She had an underlying medical condition. The overwhelming majority of maternal deaths are from a handful of different causes. So it was in some ways a complicated case to take, and the issue of the two institutions with divided responsibility, and that one of them was private and not state, was also an issue. So does anybody recall anything about the holding or the recommendations? Because they are recommendations. So that's fine. The case is really known for three things. They found violations of access to justice and redress at the national level, which they almost always have to do in an international case where you're arguing futility of domestic remedies or exhaustion. But they also found this is really why everybody talks about Aline. One, the CEDAW committee, for the first time, articulated a reasonably sophisticated understanding of intersectional discrimination. That is, Aline was Afro-descendant and faced a series of barriers to access to health care and a life of dignity because of that in Brazil. She was also a woman and faced barriers because of being a woman, and she was also poor, So, and the idea that these are not additive factors and that they're not to be analyzed separately, but that we understand human beings in a context where the multiplicity of dimensions of their identity come together to give them an experience of rights or a violation of rights, was not well developed in international law, and still is not very well developed, but this case does a pretty good job in elaborating that concept, and that's one of the things the case is known for. A second thing that the case is known for is obviously finding that there is a state obligation to provide emergency obstetric care, a positive, affirmative obligation, and that the lack of that provision constituted discrimination, because this is the CEDAW committee, discrimination against women. And that was pretty major and significant under international law. Because, of course, it implied a whole series of budgetary changes and systemic changes that international treaty monitoring bodies are reluctant to engage in. The third thing that the decision did, which really makes it path-breaking, is call upon the state, say, it doesn't matter that one of these institutions was private. You, as a state, have a due diligence obligation to regulate the conduct of private actors. Brazil has a remarkable public health system set up in conjunction with the 1988 Constitution, theoretically a unified health system, but in fact, there are now a lot of what are called convenios between private sector and the Brazilian government. So that made the judgment extraordinarily important. And lots of law review articles were written about it, lots of fanfare. So how does it get implemented? The committee made individual recommendations on compensation to Aline's daughter, Alice, who is a lovely young woman who I've met several times, and to her mother, Maria de Lourdes. And also about sort of symbolic reparations of putting up plaques at hospitals, et cetera. And then it made a whole series of general recommendations. And you can see that they're pretty broad. Ensure women's right to safe motherhood and affordable access to emergency obstetric care according to general recommendation. Provide adequate training to health professionals, especially on women's reproductive health and rights. Ensure access to effective remedies in cases when the right to women's reproductive health has been violated. Ensure that private healthcare facilities comply with the national and international studies. You know, these are quite broad. So if you are the government of Brazil, what do you do with this? Let's say you even have the political will to actually comply. How do you go about doing that? And how does the Center for Reproductive Rights establish that they have complied? Or the CEDAW committee, for that matter, that has very limited resources? Okay. So this is just a fraction of some of the previous follow-up that had been done between the government of Brazil and the Center for Reproductive Rights. And to boil this down, there had been a lot of back and forth. The center said they haven't complied. The government of Brazil had said, we've done all this. The center said, no, but that's not good enough. And the government of Brazil said, no, but we've done all this and more. And you don't understand how Brazil works. And it had gone back and forth like that for quite a while. So we came up with the idea of doing a technical follow-up mission. So the case was filed in 2008. Aline died in 2003. Case was filed in 2008. The decision came down in 2011. They had been going back and forth. 2015, the government of Brazil accepts that technical experts, public health experts, and then the CEDAW committee accepts, and the Center for Reproductive Rights is sponsoring a mission by technical experts to follow up on the implementation of this decision and see if the logjam can be broken. I was one of those people who went on that follow-up mission. And to answer the question I posed before about how do you begin to figure out what the government of Brazil is doing or comply, I had, and this goes to sort of the iterative nature of international law, I had written that UN technical guidance on a human rights-based approach to maternal health. So I used it, we decided to use it, looking at all of the dimensions of the health policy cycle to see whether there were enabling law, and this is all drawn from other sources of international law, but seeing whether there were enabling legal frameworks and policies, looking at national plans and strategies, looking at budgets, program implementation, monitoring and evaluation strategies, and remedies. So we very systematically, and this is not easy in a country like Brazil, went through each of these rubrics. And just because my time is running out, so in the enabling legal and policy framework, Brazil has a lot of great laws. They also extraordinarily lack a law on obstetric violence. And obstetric violence is more than disrespect and abuse. It's also the medicalization of natural processes. In Brazil, they have cesarean rates that are over 80% in many private facilities. There's a lack of legislative parameters for that. National strategies, plans of action, they had just a plethora of different strategies and initiatives that they had actually implemented since the Aline case. The main one was one called the Rede Cegonha, which means stork network in Portuguese. And just to give you one example of how we looked at this, one of the thing about the Rede Cegonha was it was based not on sexual and reproductive health and rights, which is what CEDAW wanted, but on a reproductive, maternal, and child health frame. And that semantic difference, because in this area, perhaps more than any other in global health law, discourses and narratives matter. And changing sexual and reproductive health and rights, where women are agents who want to participate as equal members of society, to a frame where women are instruments of reproduction and measured in terms of their reproductive capacities and desires only, is very problematic. And when that is the plan of action, the programming follows therefrom. So we made a whole series of recommendations about that. And in budgets, we found that despite the fact that Brazil actually has a pretty high spending on health, 2/3 of it was going to the private sector through these convenios, which is extraordinary. Implementation of programs, we looked a lot at implementation of programs at different levels, and found, for example, a lack of alignment between what they said they were going to do and what they were doing, which was, so for example, in Brazil, there is only one medical school that teaches assisted vaginal delivery in Pernambuco. So if you don't have doctors who understand how to do assisted vaginal delivery, your C-section rates are going to go through the roof. But you need to be able to look at what is being taught in curricula. You need to be able to understand what is necessary, how it's functioning, so whatever they say about their intentions to reduce cesarean rates, to do this, if doctors aren't trained in it, it's not going to happen. So we looked at all of those kinds of things in monitoring and review. They had an enormous number of frameworks for monitoring, but they were completely fragmented between federal, state, municipal level, and collecting the information was a mess, and it wasn't clear that the actual information was leading to action and evidence-based implementation thereafter. And remedies, we also looked at remedies. Judicialization of health in Brazil is a big issue, and we're actually going to do, at OneillH, we're going to do a roundtable on that at some point. But this was really looking at broader remedies that were not blaming the providers, but looking at structural, systemic interventions by the Ministerio Público. So we went through all of this, came up with a report, and the government of Brazil, remarkably, given that Brazil has had extraordinary political turmoil and undergone economic crisis during this period that the report came out, has actually received the recommendations very well. They've been transmitted. They're translating them. They say they are committed now to bringing together an intersectorial team to trying to implement them. And it has sort of broken at least the logjam temporarily, and we'll see what happens from there, which is always the way I think approaching these things is, cautiously optimistic, but also let's verify down the line. So moving back to a broader picture, during the time that we were doing this, 2015 came, the MDGs ended, the Sustainable Development Goals were developed. The Sustainable Development Goals are in many ways much better than the Millennium Development Goals. They develop a universal framework, so aid isn't something of charity from north to south. It is about inequalities in rich countries, as we heard RM say. There are horrendous disparities and inequalities in this country. It is about intersectoral implications and isn't so siloed. The 3 health goals in the MDGs are: 1, health goal of universal health coverage in the SDGs, but for example, sexual and reproductive health is also in the gender equality goal. So that is a significant advance in my view. There are lots of other problems with the SDGs as well that I am happy to answer questions about. But there are advances, and we have learned something from the flaws and inadequacies of the Millennium Development Goals. One of the things that I think we are making some progress on, but I'm also healthily skeptical, is the notion of linking up human rights and human rights systems and frameworks with development. So after the Secretary General announced his first global strategy on women's and children's health, which was in 2010, it was really about there's a lack of accountability. There's a lack of accountability in women's and children's health, and really a lack of accountability in the MDGs. There were no indicators or targets for development partnership for development. And the Commission on Information and Accountability under the WHO developed an accountability framework. That accountability framework very tidily omitted remedies from it. So it was monitor, review, and act. And act is a pretty vague, wishy-washy word to a lawyer. And also seemed to skip. There was a lot of language about human rights bodies in Geneva, but nothing about the legislative and regulatory and judicial functions in countries, which is kind of like saying, well, we won't have health centers and we won't have district hospitals, but there'll be a really good referral center in Geneva for everybody to go to, and act like that's going to solve the problem. And so when the new SDGs were created, and and the Secretary General appointed a new independent accountability panel on which I am. There are 10 of us from around the world. I immediately espoused shifting the framework to include remedies and bring this into line with international law. And I'm proud to say that the first report does that, and we talk a lot about human rights, a lot about human rights. And it wasn't, and I'm also proud to say that my colleagues on the panel also understand the importance of this, and it was completely a collective decision to do so. I think, again, the issue is how to implement, how to make this meaningful in people's lives and really make the SDGs, the global strategy, something that is not just more rhetoric at international levels. So, last three quick things I'll say. When you're doing legal advocacy, I would urge, from my experience in this, to be as reflective as possible, as aware as possible about the invisible architectures that determine the funding impetuses, the development agendas, and the indicators that are used that drive funding, drive policymaking, drive programming, and drive advocacy, and the kinds of arguments that we can make, and then how they are implemented. And the second point is the importance of implementation. To make a difference in women's lives, which is what we all care about, and also because the legitimacy of legal institutions in this country and at international level especially, where the scaffolding of normative development is so much more precarious, really depends on social legitimacy and implementation and showing that there is an impact. And the final thing I'll say, which is something that goes back to what Aram opened with, I might be sort of like the William Shatner of maternal health as a human right. Like, that's the only role I keep coming back. Litigation in India, yeah, Ali. Litigation in Africa, litigation in the UN, this. And lately, I have started to say, it's not about reducing maternal mortality. It's about letting women live lives of dignity. And that shift in the evaluative space is, I think, the key to making sustained social change. It's really hard to make and really hard to do in global health, but I think that is what is required and so difficult in a world that is overrun now with the need for quantitative measurement and indicators. But you heard both from Aram and Victoria that the idea is letting women have choice, autonomy, entitlement in their lives, being human. So I'll stop there. Thank you.
Yes, I was going
break.
to say
Yeah.
just 5 minutes,
Yeah.
yes, please. very impressed.
I got more nervous.
So, yeah, I may just stand up.
Thank you. But I'd love to know it as always.
Okay, we have like, I'm familiar with your ordinium that's involved.
Yeah, we she was here to see on Monday, and then I didn't hear back.
I was the token representative, only white.
Definitely, and we're starting to figure out how to bring the back pattern and how we want to.
Yeah, I wouldn't take it off.
Good for you.
Interesting, it was amazing, but also disheartening.
It is a course, but it's a one-weekend intensive course.
Oh, really?
And it's, yeah, it's doing the contracts and the negotiations. We're gonna ask, it's 4 days, so it's Monday through Friday, unfortunately. January actually left, but we'll have some syllabus and all the
Yeah, I'll definitely write you.
wondering if,
Okay, yeah, I'd love to follow up. Thank you.
if they have any questions about,
Please.
I mean, obviously we'll talk to them.
By Sky.
Well, this would be, if you were to join it, it would be happy when you're before that.
Sure, yeah.
But then also,
For as much as I know, sorry.
yeah. The other thing that would help is maybe during the session. Participating or interviewing experts.
Are you home for a baby, or what's going on with you?
As far as I know, I hope not. No,
But also,
no, that's family's here.
Yeah, yeah.
Georgetown, no, my family's in,
so,
It was at East.
coming up for his birthday.
okay, so we can, maybe we can figure out with Money Up and if someone during the negotiation.
I'll be happy to Skype you. But it'll be 4 days of simulation.
Yeah.
But you need to be tomorrow. Yeah.
But no, it's it's not for, yeah, so they have to work and it's a lot. Just all this is from scratch.
You divide them in.
Yeah, so there'll be different countries that will have a society group. Some of them will be big groups that they do and small.
I think I've actually seen those things, yes.
You should have the US, which is on the 5-year
Definitely have a we're figuring all of that out. But once we have more, I'd love to sit down and show you.
God forbid we separate it all. Festivities. Yeah, that's fine. For Halloween.
Leslie's son, who's 5, working, yes, he's been working on
That's, I mean, I was actually,
Making me sad. My kids have like aged out of that. Yeah, the only thing we want is like students in the neighborhood.
And nobody wants to give them
Yes, they do.
Oh, no,
Of course they do, but I mean,
Yeah, so it's like, it's not cute, they don't, you know, they don't wanna
this
cry
is what I have to look
pumpkin
forward to.
anymore.
I have a few years, right? How old are your kids? Yeah, okay. All right.
you have a while.
He's still young and cute. We live on the hill, so,
I know that not everybody's back yet, but we want to get in as many questions as possible.
Yeah,
So
yeah.
you guys are the lucky ones. You get to chime in first. I know there was a lot of rich discussions that have probably elicited a number of questions from you all. So would anyone like to start with a question for
abortion if this kind of abortion is only based on the gender of the fetus. Because in my country, in China, especially in the rural area, there are still many people, many families, they prefer to have a boys rather than a girls. So if they know that they have the fetus is a girl, they may choose abortion. So right now, the Chinese government try to limit the ways that the people, the families can get the information of the genders according of the fetus. So whether this kind of measure of the government is a violate of the rights to for the families, especially for the women to be informed, to get enough information.
Should we take a bunch of questions, or
Sure, we
should
can take more than one. So go ahead, I know you can.
So I had a question about, the statistic you gave, Dr. Jennings, about the 23% of women don't seek reproductive services because they or their partners are opposed to it on some ideological level. And I just wonder, how do we begin to address that? Because I feel like that statistic must be much higher for other countries, like, for example, in Africa. And is that something that we can intervene with on a legal level? Is it something that governments should be intervening with, particularly given that it's based on people's personal beliefs, although it is such a massive barrier towards women accessing these services?
One more? Is there one more question for this round? Okay. Oh, yeah, sure.
When Professor Jennings was presenting the methods of choice, my question is, who chooses? Are those methods there because of the people's choice, or the government? Are they there because the government makes those methods available?
You start with the easy question on sex-selective abortion. Yeah, no, that is a challenging. It's a challenging question, and I think obviously, I think people have, for very good reason, a strong reaction when they think about someone terminating a pregnancy based on the gender, and understandably people find that upsetting. I mean, I think the answer that I would give is one, and there's a fantastic interagency UN statement with UNFPA and UNICEF and WHO that they put out about 5 years ago or so. And it talks about sort of how to address this issue, which is a challenging one. And basically what they conclude is they say, look, what's effective is looking at the underlying factors. Why sex-selective abortion and valuing boy children above girl children, which it almost always is, although there's actually a correlate to that, which is not always true, which is interesting too, stems from kind of a broader set of systems and a broader set of discrimination that systematically devalues girls or increases the value of boys. And that if you want to address the issues of it, if you want to try to address sex-selective abortion, the way you do that is you need to address these underlying factors, and consequently that efforts to try to restrict or ban abortions based on a woman's reason for choosing an abortion, or even the prenatal sex test. Stop hitting that microphone soon. Even trying to ban, prenatal sex testing like they have done in India, is not something that's ultimately effective. And cynically in the United States, there's a bill, PRENDA, called the Prenatal Non-Discrimination Act, which people, sort of conservatives, have wheeled out, and potentially with prison time for doctors and potentially women, and oftentimes these efforts are really about sort of trying to reduce access to abortion. I think there's an understandable reason people find them upsetting, but banning abortion or trying to ban those kinds of procedures and criminalizing women and their doctors is not the way to do it, and that is the consensus of the international community. And this international consensus statement from these different UN agencies is available online, and I encourage you to read it. I think it really treats the matter with sensitivity and thoroughness. I don't have sort of thoughts on. Maybe I'll pass the other questions on to you guys. I think they're more towards you.
I don't have any comments on that particular topic. I think like a lot of people, I find it somewhat upsetting, and work in a context in India, in northern India, in the state of Jharkhand, where it is very, very common and where the sex ratio is quite skewed. But I would say that that sort of discrimination does not end with abortion. It persists after the birth of the baby, and the mortality rate for female infants is much higher than the mortality rate for male infants. So if people don't have access to abortion, they're going to take care of that son preference issue one way or the other. I mean, somehow the girl will continue to be disadvantaged. It is a very difficult thing, and I guess as an anthropologist, you asked about opposition to family planning, can we intervene on the legal level, and I would say almost the same thing about this issue. I am not a lawyer, I'm an anthropologist, and I tend to think in terms of social norms and the reasons why these issues are there in the first place. Why is that the case, and what can we do about it? Social norms are basically, social norm is a behavior. And it is a behavior that I carry out because I believe all of you are doing the same thing, and because I believe that you'll think badly of me if I don't do that. So if I believe that women in my community are not using family planning, and if I believe that you're going to think of me as a bad woman, or that my husband is going to think of me that way, or whoever is important in my life is going to think of me that way, I don't see a legal remedy to that. I think the legal remedies may be more around, keeping girls in school and issues related to employment and, that sort of thing. But to try to directly shift a social norm around an issue like family planning it's a very difficult thing, and I don't know, other than making family planning, free, widely available through non-discriminatory services with unbiased providers and all of those kinds of things that we're all trying to do. I don't know how you could address it further than that from a legal standpoint, but that may be my limitation on thinking about what, from a legal perspective, you can do. So I would love to hear your thoughts on that. As far as who chooses methods, that too is a really good question. Quite often, the concept is informed choice. You probably saw that word informed in a lot of those policy statements. So the idea is that the woman will be informed about all of the methods that are available, and that the methods that are available will represent a wide range of methods that could work for her. And she's supposed to learn about them or be provided information about them, and then she's supposed to choose her method. What often happens, of course, is that the provider is steering that discussion. So when I mentioned the issue about LARCs first, for example, the provider is told you will offer long-acting reversible contraception first, and only if the person refuses to accept it, despite all the good things about it that you've told her, then you can go on to offer another method. So it's a very unusual situation. In terms of at a higher level, there's a lot of politics around that. A lot of pharmaceutical companies have a lot of influence on what gets purchased by the international donor community, what gets registered in a country as a drug or device that can legally be brought into the country. Emergency contraception is one of those, for example, that's really quite, is very much in the forefront in the reproductive health field in that regard. Countries that refuse to register the product, or countries, whatever their issue may be. So that these choices are made at a variety of levels, all the way from the political level, the manufacturers, who gets government contracts or whatever to manufacture products at a cost that the government is willing to pay, what the what the pricing structure is, how they come into a country or not, what gets offered through programming. It's quite a political situation from top to bottom. The top of the pyramid, of course, should be the woman making a choice, but it isn't. It tends to be the
I don't have very much more to add, and I'll try to be brief so we can have other questions. I think, as my colleagues said, that this question of sex-selective abortion is complex and difficult, and I think it is something that requires looking at much broader contextual issues about why women's lives are devalued. I also think that if you have been in this field for a very long time, there is an immediate sort of visceral reaction because it's so used as a trope, you know, anti-femicide legislation, et cetera, by people who really want to restrict abortion more broadly. In terms of the law and what it can do, I mean, as I said, I come from a very socio-legal perspective. I think the law plays a big role in orienting social norms. So, you know, but the law is not enough in and of itself. In different areas that I've worked in the Amazon and Peru, for example, there was a very effective radio soap opera that looked at women's control of their bodies and use of contraceptive methods that actually had some inadvertent consequences, like when women tried to control their bodies and use contraception, they were subject to domestic violence. But over time, things change, and that always is a risk. So law in and of itself, no, but yes, law plays a role, I think. In terms of the methods and who decides, I think Victoria is absolutely right. But in practice, I lived for 3.5 years in East Africa. And in countries with desperately failing and inadequate health systems, it is often poor women in remote rural communities that the health system just does not reach. So they are subject to, you know, some international NGO that has a contract to do LARCs or long-acting and permanent methods, tubal ligations. And they come in a sort of a kind of tractor trailer type thing and do a fair and do operations and implant people, and then they leave, and there is no health care around for those women for a very long time. So it's not necessarily that providers even in some countries are making choices for women. It's the parameters of what happens in weak health systems.
That's very true. I think that's a really, really important point. And those very same international NGOs that come in and do that sort of work and then leave women with IUDs and implants who then at some moment don't want them and have no mechanism for having them removed.
Right.
So that can certainly be, you know, clearly very problematic. Or complications from a sterilization, which is a surgical procedure, and there's nobody there who can take care of it, and there's no transport to a facility where it could be managed. So this is not to say that these NGOs are doing bad things. It is not to say that these are bad methods. Not at all, not at all. But rather, it needs to be contextualized, and you need to think about, we need very much to think about the health systems that are so non-existent in these areas, what you can do about that, what are some strategies for getting health information and health services to these areas, a wide variety of things that we can, that we need to address. It's not, the whole thing is the system. It's not just one thing.
Yeah.
So, actually, during your presentation, you had kind of emphasized the language in Whole Women's Health being that the court had said that it could be an undue burden in purpose or effect. Is that correct?
Yeah, that's language. That's language from
Or from Casey. So I'm curious. I remember after reading Whole Women's Health, I went into similar kind of investigation of all the comments made, almost doing like kind of an Arlington Heights analysis, looking to see if there was any evidence that would have indicated the purpose of the legislation wasn't necessarily to be any way helpful necessarily, but just to oppose abortion rights. And like I looked into some of the quotes you had mentioned, as well as like seeing if there were inconsistent laws after birth or prenatal care in place, like welfare programs, to see if they're really doing things in the interest of the child's health. And I'm curious to know if you foresee that kind of approach developing in the future. If there will be more of a intent, kind of look into the intent of the legislation and whether or not that might be an avenue for future litigation.
Someone in the back has another question?
Any other questions for this round?
But it's on something different. It's
That's
more,
totally fine.
okay. I have a question about the role of law and international human rights law in particular in building consensus among NGOs, scholars, etc. And more specifically, 15 years ago, you commented on AIDS treatment and how that changed with the international responsibility, but there was a lot of resistance in NGOs, even in MSF, against the idea of providing AIDS treatment in low-income countries because of the sustainability issue of that. And the right to health and the focus on international obligation helped to create a consensus. Very similarly, there was a disagreement on emergency obstetric care, saying that the full range of emergency obstetric care in low-income countries was unaffordable for these countries. And that there never was, I would say, a clear consensus among public health scholars and NGOs that if countries are too poor to provide that, then the international community should step in. And so, I mean, how can international human rights law help to build advocacy even before convincing governments? But
Questions for this round?
One kind of follow-up on the LARCs issue. When you said that the donors, like I don't know, maybe you can't give this information, but you had mentioned that the donors are targeting the rural areas and adolescents specifically. Is that USAID's policy to prioritize LARCs for adolescents? Just because it does seem very concerning at a young age to have something that would have to be reversed in a country where they're not going to have access to it, as you mentioned. And then I also wondered why they're going to that as the first priority when a lot of these countries might have high HIV/AIDS prevalence, and because that's not going to address that. And so why the shift there instead of still maybe, I guess, trying to take new approaches with access to condoms?
Can I make a comment about underburden? My view of underburden, and we actually did a small study about litigation that had happened on these state law initiatives since 2010, 2011. And the circuit courts were all over the place on whether they looked at clinical evidence and public health evidence or not, therefore sort of shifting the burden of proof to the woman to say, well, oh, it might be Larry's granddaughter. It's exciting. So in some circuits, the idea that the laws were presenting no real, there was no medical benefit was taken into account, and in others there were not. And some, including the Fifth Circuit, would say it is completely fine to have speculation that having an abortion would cause women to have suicidal thoughts and tendencies later. So that the Breyer's opinion, which is in some ways quite workmanlike, is masterful in saying, well, what we consider to be normatively acceptable has to be reasonably related to fact. And it seems obvious to us, but actually it has not been in the past in many ways. On emergency obstetric care, I think the narrative is somewhat more complex for it. And I know you've written about this, and Because to address maternal mortality, you need access to contraception, you need access to abortion and legal changes, you need skilled birth attendants and emergency obstetric care and referral networks, which is a much broader array of things than HIV treatment. And also, there were all kinds of issues around the indicators that were used. So skilled birth attendants is a deplorable indicator, and really drove institutional delivery that created a whole nother series of messes, including obstetric violence, in my view, 20 years later. And the idea that entitlements, without all of the things surrounding it, for women, the autonomy, the choice, the equality, wasn't going to do it. And there's not the same defined advocacy community. But this is a much longer conversation, which I'm very happy to have with you.
Talking about the donors and LARCs for adolescents, first of all, the definition of adolescence is quite, as you may know, quite broad. And it includes, married youth who are 18, 19, 20, up to 25 years old, as well as very young adolescents, as young as 12. Sort of the 10 to 14 category is called very young adolescents. So clearly there's this wide range. But your question, actually, I believe you were focusing on what about in circumstances where they're not going to be able to have them removed. Clearly that's an issue. But what about even in circumstances where potentially they could? And I would say here in the US is an example of that. In the Title X program, again, the choice, LARC's first model, is encouraged among family planning providers. And that includes family planning providers who are offering services to adolescents. And indeed, the teen pregnancy rate has plummeted in some part because of this decision, because of this policy. So, it has an effect that we might say, well, that's a good thing. On the other hand, it is within a context in which you have to say, but where is this woman's choice? On the other hand, et cetera, there's always another hand, right? You asked specifically about USAID, and USAID has official policies around choice. But in practice, USAID is putting the large amount of its programming, of its budget, into programming that supports long-acting and reversible contraception. So LARCs is a very, very important component of the USAID program, including services for adolescents. So and that's just a fact. I'm not saying, and it shouldn't be that way. I'm just saying, and that's the fact. So you asked where that came from. In terms of looking in circumstances with HIV prevalence, what we don't want is for her to be both HIV positive and pregnant if she doesn't want to be pregnant. And there are, in addition to condoms, there is a development of multi-purpose technologies that's going on. There's a lot kind of bubbling along in the pharmaceutical arena. And then in devices, drugs, other sort of drugs and devices, I guess you would say, that address the dual issue of sexually transmitted infection, acquisition, and pregnancy. So these things are being looked at, but the use of condoms around the world is pretty low. Probably won't get higher. In some countries, Japan, for example, it's quite high, but in most countries around the world, quite low.
Yeah, just a couple of things. To what's been said, although it's sort of gilding the lily a little bit. Yeah, I think, as Alicia said, the decision on whole woman's health does represent a change and a move away, certainly from what the Fifth Circuit did and what other circuits have done in some cases. It's just this, undue burden is kind of, it is what you think it is, and it became, there were a couple of things that were struck down, spousal notification law, but a lot of things were upheld under it, including spousal consent or parental consent and parental notification for juveniles, at least with the existence of some sort of override. So yeah, I do think it's different. Obviously, the decision is almost literally hot off the presses, and so knowing what this will mean and what the Supreme Court will do with it going forward, and there's obviously a huge amount of ways the Supreme Court could go depending on what happens in November, and of course what the circuits do, because very few cases actually get to the Supreme Court, is going to have a tremendous influence, but certainly there's a strong impetus for a much more searching requirement. That's sort of just the legislature saying in official documents it's for health. That's certainly not enough. You have to go beyond it. I think the Texas law where there weren't exemptions, where it was in some ways a strong case because it was so extreme. And I think, things that are going to be at the level of Texas likely are going to be overturned by circuit courts and likely would not be upheld by the Supreme Court. Of course, you can always play, well, what if it's not a 10 on the badness scale? What if it's an 8? What if it's a 7? And I think that's when it gets more tricky, where there is some demonstrable medical benefit, but how do you weigh that versus, and I think that's sort of, where we're going with it. And then just another point to the question about LARCs, I think there's a couple of lessons here that I think are important. I think we always think about these things from our own perspective, like, well, you imagine kind of counseling on contraceptive methods as the way that we might get counseling here, and of course, nothing could be further from the truth. I mean, you're dealing with rural areas, you're dealing with low resource setting, you're dealing with people oftentimes who lack significant education. And even here in the United States, if you see your doctor and your doctor said, well, here's 15 different things you could do, most people's question will be, okay, which do you think I should do? And so it is difficult to sort of have complete objectivity while still being helpful to the person. And so I think certainly there's also, of course, the whole backstory of coercion and kind of a population control background from the 60s and 70s that I think we're still getting over, and I think it's important to have a human rights model, and that some of this is also colored by past experiences. There are studies in the United States. There was a choice study out of Washington University that predated the contraceptive coverage benefit, where they essentially provided something just like the contraceptive coverage benefit, saying you could get whatever contraception you wanted regardless of cost, and we'll pay for it. And people did migrate towards more expensive, more effective methods. I mean, there is something about that that makes sense. It's much more effective. I mean, the failure rate with actual use for condoms, even with birth control pills, is very high. I was sort of surprised. Guttmacher has some statistics on it, and you really have to look at actual use because no one uses birth control in the lab. And then the last thing, I think, just also about kind of unintended consequences, I think is interesting. I think the point about, would you rather have a skilled birth attendant or an unskilled birth attendant or no birth attendant? Well, a skilled birth attendant sounds great, right? I mean, who doesn't want to have someone who knows what they're doing there? And then, of course, that then creates certain set of incentives that then lead to an outcome that might not have been what was intended. I think there's concerns around kind of pushing LARCs first. I think it's not motivated by a population control ethos in the way that some programs, I think, were possibly in the 60s and 70s, and certainly resulted in that. But I think there is a real concern about unintended consequences and thinking about, how this policies that make sense at one end, once they get implemented in the field, how they actually work out, and that they can create then other problems in turn is instructive, although a challenging problem to overcome.
Can I just make one comment in general about this whole field, picking up on what Aaron was saying and something else that Victoria had said previously? Well, first of all, skilled birth attendants is such a deplorable indicator because the way they come up with that is through household surveys, and they ask women, in your last pregnancy, were you attended by a skilled birth attendant? And if you're a rural, illiterate, uneducated woman and you went to deliver in a health center and somebody who was wearing some kind of jacket, if the person is a cleaner, they will say, I was attended by a skilled birth attendant. So the comparability and objective value in that indicator is pretty close to null, and everybody who works in reproductive health knows that, despite the fact that it continues to be used over and over and over again, and drives policies toward institutional delivery that actually do not provide emergency obstetric care. But more generally, it's a good example of how indicators, like and in this world now, in the SDGs, we are awash in quantitative indicators. Absolutely awash in monitoring frameworks that reduce everything to crystallized outcomes and outputs. And in fact, human rights are now being compiled into synthetic indicators. And again, going back to the be careful, be reflective about what is going on, because it's very seductive to want to measure something, because what gets measured, what gets counted, gets pushed in policy and funding, but it can actually obscure far more than it reveals about the underlying power relations in a context that is what we should be caring about for human rights. And, you know, my fear is that in the enthusiasm for these indicators, we lose sight of, we talk about, well, they've gone up in this rights indicator, and it's not real. It has absorbed all of the uncertainty, all of the contextual factors that anthropologists tell us to pay attention to, and crystallized it in something that is really divorced and meaningless. So I think we should all be reflective about the bandwagons we jump on.
And I think we'll need to end there because we're over time, but please join me in thanking our fantastic panel.